Shashidhar sir, shall we start in 2 minutes?
Hello. Yeah. I think another 2-3 minutes we'll start.
Yeah. Yes.
Thank you. Dr. Rochelle, I think we can start now.
Yeah, yes. Sir. Good evening, everyone, and a warm welcome to this session on IAMM Masterclass brought to you by the Karnataka chapter. And warm greetings because it's a very auspicious day today. Being Vara Mahalakshmi festival, I think some of them are busy with that. And I wish all of you health, peace, and happiness in your life. So, coming to the topic that is for today, we have a very interesting, a very basic, but a very versatile topic that forms the cornerstone of clinical microbiology. All of us as microbiologists appreciate and understand that antibiotic sensitivity testing is one of the most important skills and the knowledge behind it that a clinical microbiologist should understand. And it's only on this that we build up the interpretation, the AMSP that we practice later. When it comes to antibiotic susceptibility testing, there are certain parameters that need to be taken care of in the laboratory. And to do justice to this topic, we thought we should first address the very basics, that is, the quality control in antibiotic susceptibility testing. And as a speaker for this, we have Dr. Archana Bhat K, who is an associate professor at the Department of Microbiology at Kasturba Medical College, Mangalore. Welcome, Dr. Archana. Dr. Archana?
You're muted, Dr. Archana.
Yeah.
Yes, Dr. Archana. Welcome to this masterclass.
Thank you, ma'am. Thank
And
you.
we look forward to hearing from you. So it is
Yes.
my pleasure to introduce Dr. Archana to all of you. As I said, she is currently the associate professor at Kasturba Medical College, Mangalore. Having completed her MBBS from Sri Siddhartha Medical College, Tumkur between 2003 to 2009, she went on to pursue her MD in microbiology from Bangalore Medical College and Research Institute, BMCRI. Following which, Dr. Archana has practiced as a registrar in microbiology at the diagnostic laboratory attached to KMC Hospital, Mangalore. And then she served as assistant professor and is currently the associate professor in the department. And KMC Mangalore, as you know, is attached to Mahe deemed to be university. Dr. Archana has engaged herself in UG and PG teaching for MBBS, MSc Medical Microbiology, and MD courses. She is also an internal auditee for NABL and a guide for MSc and MD PGs. Her special interests are antimicrobial resistance, molecular diagnostics, and mycology. Dr. Archana is a life member of Indian Association of Medical Microbiologists and has more than 18 publications in national and international journals. So we have a very apt speaker, and it is my privilege on behalf of IMMKC to extend a warm welcome to Dr. Archana Bhat. Over to you, Archana.
Thank you, ma'am, for this kind introduction. So before we begin, I would like to thank the organizing committee of IMKC Masterclass for giving me an opportunity to be a part of this educative program. So with this, can I just share my screen, ma'am?
Yes, please. Yes, yes.
Yeah.
And also request to all the participants, as the session progresses at any stage, if you have any doubts, queries, need to ask anything, please do drop it in the chat box and we'll take it up as after the session.
Is the screen visible,
Yes,
ma'am?
yes, Archana, absolutely fine. Yeah. Yes, you're on the first slide.
Okay, thank you, ma'am.
Yes.
So the topic for today, so can we start, ma'am?
Please, yes, yes.
Yeah. So the topic for today is quality control in antibiotic susceptibility testing, both conventional and automated method. So to begin with, first we'll understand what is quality control and what is quality assurance. So quality control monitors the analytical phase of the test process, Whereas quality assurance includes both pre-analytical, analytical, and post-analytical phase. And quality system is an institution-wide program which ensures the entire workflow is quality driven. What is the importance of QC in AST? So QC ensures accuracy and reproducibility of results. It prevents reporting of incorrect susceptibility data, and it is a requirement for accreditation and surveillance programs. So to begin with, let's first discuss what are the primary variables or what are the factors which can be controlled when performing a routine conventional AST. So to begin with is the media of choice. So it is recommended that we use the Muller-Hinton agar for this diffusion and cation adjusted Muller-Hinton broth for broad dilution method. So the pH recommended is 7.2 to 7.4. They have to be stored at 2 to 8 degrees centigrade and the plates are stable for up to 7 days. So the thickness of the plate ideally should be 4 mm. Batch to batch variability. So apart from that, it has an optimal concentration of divalent cations, that is calcium and magnesium. Supposedly, there is an increased concentration of calcium and magnesium. The result is that the activity of the aminoglycoside decreases against Pseudomonas aeruginosa, and the tetracycline activity also decreases against all organisms. Hence, it is important to test any new lot of MHA against Pseudomonas aeruginosa and aminoglycoside. So the media MHA is low in thymine and thymidine as well. So the media containing excess amount of thymine or thymidine can decrease the activity of sulfonamides and trimethoprim. So this can lead to false resistance reports. Here again, the new lot of MHA has to be tested against Enterococcus faecalis 80cc strain to check the efficacy of the media. So the zone diameter ideally should be more than equal to 20 mm. So if 20, then the media is said to be satisfactory. Less than 20 mm zone of inhibition with respect to trimethoprim sulfamethoxazole disc, the media is said to be unsatisfactory. So the newly prepared media has to undergo a sterility check and a performance check. So to begin with, how do we go ahead with the sterility check of the media? So incubate 5 to 10% of the whole lot for 48 hours at 35 degree. And if more than 10% is contaminated, then it is a significant contamination. So in that case, we can discard the entire batch. So any sporadic contaminant, say for example, just one piece may not be significant. One thing we have to remember is whatever the media has been used for sterility cannot be reused. So they have to be discarded. So the media that is prepared has to undergo a performance check. Here we are checking if the media is supporting the growth of the organisms, that is non-fastidious, gram-negative and gram-positive bacteria. So in such cases, these are 80cc strains which are recommended. That is Escherichia E. coli 80cc 25922, Pseudomonas aeruginosa 27853, and Staphylococcus aureus 80cc 25923. So the expected result is good growth of these 80cc strains. So this completes the sterility and the performance check of the media. So the media which is prepared should be ideally moist. So with no evidence of water droplets, neither on the surface of the media nor on the lids or the covers. So in order to dry the plates, so we can keep these plates in the incubator of 35 degrees centigrade, but never more than 10 to 30 minutes because the media will dry up. So just you have to dry these plates just prior to the usage. The next component is the antimicrobial disc. So remember, whenever we are buying any antimicrobial disc, we have to buy it from a reliable vendor. At the time of receiving, please check the content of the disc, the lot number, and the expiry date.
Dr. Archana,
So, if I may ask, regarding the test which I did with Shakeen,
I think our connection is lost.
yeah,
Probably
Dr.
should log in
Archana,
again. Yeah, you can log in again. You just call and tell me.
Shashi, Shashi, tried calling Archana. The number busy birthday.
yes, I have, sir, I spoke to Archana. She's just relogging. Just will give her 2 minutes.
Dr. Rochelle, were you able to contact Dr. Archana?
Yes, sir. Yes, sir. I just spoke to Dr. Archana. She's just trying to relog.
Okay, okay, sure. Thank you so much. Thanks.
Meanwhile, just to add on, somebody has asked a question why Muller-Hinton agar is used as the media. So I would like to answer this. I'm Dr. Suchitra speaking. When Dr. Archana is going to come online. See, Muller-Hinton agar is used because of the consistency it can maintain, having very less amount of any kind of antibiotics, and the starch which is present in the Muller-Hinton agar will actually absorb the bacterial toxins, so it will not inhibit the diffusion of the antibiotics. It is one of the standardized agar medium which can be used for AST, which is actually advocated by CLSI. But the other one is isosensi test agar, which is used by UCAST, which is similar to MHA, but these two are actually used exclusively for non-fastidious organisms. This is something which we have to keep in mind. For the fastidious organisms and anaerobes, it would be different kinds of other agars. I hope I've answered the test, the questions.
Yeah, yes, madam. Yeah.
Yes. Thank you,
Dr.
Dr.
Archana has network issues. She joined. Okay.
Thank you, Dr. Suchitra ma'am, for that explanation. And I think we can also add in for the same question that it is also having a lower concentration of thymidine and thymine, which if they are in high concentration, can perhaps, give a variability in the zone of inhibition for sulfonamides and few other antibiotics like tetracyclines. So this also is one of the reasons. And as ma'am said, why it is a preferred media, and I think she answered that question. Thank you, ma'am. I think Dr. Archana is back. Dr. Archana? Dr. Archana, are you able to hear us?
I think she got logged out again. We'll just wait for a minute. She's joined. Dr. Archana, can you hear us?
Ma'am, my screen is not, I'm not able to share. I just switched on the mobile data. Just a minute, ma'am. Ma'am, is my screen visible, ma'am? Okay, sorry, ma'am, sorry. So, yeah, where did we stop? Okay, okay.
Somebody sit down. Sit down.
Sorry for the technical glitch. Am I audible now?
Yes, yes, Dr. Archana. You are,
Yeah.
you are.
So we were discussing. So can we continue, ma'am?
Yes, yes.
So
from the quality check of media onwards, that quality check of media, I think we were all able to hear.
okay.
We have completed that, yeah.
Okay, so we'll just continue with the essentials of the antimicrobial disc. So we have to buy from a reliable vendor. So apart from that, at the time of receiving any new antimicrobial disc, check the content of the disc, check the lot number and the expiry date. So what should be the ideal storage temperature of antimicrobial disc? So it is at 2 to 8 degree in the refrigerator or a non-frost-free freezer. So in case of beta lactams, they are stored in at -20, except for a small working supply, which may be refrigerated for up to a week. Imipenem and clavulanic acid combination are labile. Hence, they are better stable if they are stored frozen until the day of use. So it is important to bring this disc to room temperature just prior to use. In case of broad dilution, antimicrobial solution are stored at -20. Imipenem is again labile, so better stored at -70. These solutions are stable up to 6 months, and for subsequent use, it is ideal to thaw, and once thawed, never refreeze. Each new lot of lot of antimicrobial disc that has been received has to undergo a quality check with the appropriate QC strain. So that is called as lot verification. So once we discuss the media and the antimicrobial disc. So let's move on to the inoculum standardization. So we all know that 0.5 McFarland standard is the one which is recommended. So it has to be stored in the dark at room temperature and in tightly sealed tubes. So this 0.5 McFarland has a tendency to evaporate. So to avoid that, tightly seal the tubes and store it in the dark. And prior to use, vortexing is a good practice. So once prepared, the OD value of 0.5 McFarland should at 625 nanometer should be 0.08 to 0.10. So this OD check has to be repeated monthly, and if it is in control, we can extend the shelf life of the 0.5 McFarland up to 12 months. Supposedly there is any clumping or any evaporation of the 0.5 McFarland standard, we should not be using it, and we have to discard and prepare a fresh one again. So this is the quality control for the prepared 0.5 McFarland standard. So selection of the colony is a very crucial step in quality control of antimicrobial susceptibility testing. So always use a sterile loop, touch the top of 3 to 4 morphologically similar individual colonies, and never use growth from plates which are more than 1 day old. So this is a very crucial step in the reliable result for a reliable result for AST. Then we can either use a broth culture or a direct colony suspension method as per the CLSI guidelines. And then we need to adjust the turbidity with 0.5 McFarland, and mainly by placing a white paper or a card with black lines. So if we do not have a card with black lines, we can use a newspaper print as well. So remember that the prepared inoculum has to be used and inoculated into MHA within 15 minutes. When it comes to the inoculation process, we have to avoid too much of inoculum. So how do we avoid this? Mainly by pressing and rotating the swab against the side of the tube. Then the plate is swabbed in 3 directions. Rotate the plate at 60 degrees. So this ensures even distribution. As a final step, the rim of the agar has to be swabbed. Then what should be the minimum distance between the two antimicrobial discs? So we should remember that when we measure center to center of the two discs, it should be at least 24 mm, never less than this. So apart from that, what should be the distance from the edge of the lid? So it should be minimum 15 mm away from the edge. So we can place up to 12 discs in a 150 mm plate and up to 6 discs in a 100 mm plate. Always use a sterile forceps or a needle which is mounted on a holder. Supposedly a disc is wrongly placed or we have placed a wrong disc, then never attempt to relocate the disc. So instead what we can do is place a new disc in another location on the agar. We can use such in-house prepared templates for applying the antimicrobial disc. So, using such templates can minimize errors while placing the disc. So this will ensure the minimum distance between the two discs is ideal and uniform across all the plates. That is minimum, it should be 24 mm. Then what are the incubation conditions? So it is 35 degree for 16 to 20 hours, and the atmosphere is ambient air until and unless it is specified that carbon dioxide is a requirement. So this temperature and duration of incubation, you can refer to CLSI for the individual test isolate. So we should remember that never stack the plates more than 5 plates high. Do not stack the trays more, if at all we are using MIC trays, never stack the trays more than 4 high, and all the micro dilution trays are to be sealed. The next variable which is important is the reading of the plates and interpretation. So observe the lawn culture. So read only if the lawn is confluent or nearly confluent. So this is a confluent or a nearly confluent lawn. So here it is very easy to measure the endpoint. When we compare it to the AST plates shown in the left, so these are not good. So here it is not a confluent inoculum, and here there are gaps in the lawn. So it is clearly indicated that the plate is not ideal. It is not rotated 60 degree. So in such cases, the endpoint determination is the challenge and very difficult. So it is ideal to repeat the antimicrobial testing. So when measuring the endpoint, always use a black background. Measure the zone from the back of the back of the plate, and for opaque plates, remove the lid and read from the top. Always use reflected light. So except for staphylococci and enterococci. And also use always measure the zone by using a unaided eye. So any faint growth of tiny colonies which can be detected only by using a magnifying lens are to be ignored. So always use an unaided eye and reflected light except for staphylococci and enterococci. There are certain unusual zones which may be encountered. Say, for example, trimethoprim and sulfonamines. Here, the endpoint measurement is 80% reduction in the growth. So, in such cases, measure the margins of the heavy growth and ignore the light growth. In case of Proteus species, ignore the swarming of Proteus. In case of double zone of inhibition, always measure the inner zone. Supposedly, there are tiny colonies within the zone of inhibition. So it is ideally recommended to repeat the antibiotic sensitivity testing. So this could be either due to a mixed culture or a resistant subpopulation. Then, what are in case of broad dilution, always ensure proper lighting and observe for the growth. So how do we measure the endpoint? We look for the turbidity or the button of growth. So the button of growth more than 20 mm is considered as growth positive. So always run controls, that is ATCC controls with each test strain. And if available, we can run an in-house positive control. So always check the growth control well for the evidence of growth. And also we include a media control. So media control should be clear. So only if the growth and the media control is satisfactory, then as well as the QC strains are satisfactory, then only we can go ahead reading the MIC. There are certain challenges during endpoint determination of a broad dilution. One such is the trailing effect. So this is the trailing effect. So sometimes in cases of trailing effect, always observe for the diameter of the button. So remember that the diameter of the well is around 7 mm. So any tiny button which is less than 2 mm will be ignored. And in case of trailing effect, read the first well where the trailing begins. Another challenge is the skipped well. So the skipped well is here ideally in a properly executed MIC, there will be no growth at a higher concentration of the drug, whereas growth at lower concentration. Here, in case of skip well, it's a vice versa phenomena where there is growth at higher concentration of the drug and no growth at lower concentration. So, what are the possible reasons for skip well? It could be contamination, inadequate inoculum, or a not properly mixed well. And improper antibiotic concentration in the well, or alternatively due to resistant subpopulation. So ideally, in case of skipped well, please repeat the AST. What is the reproducibility criteria during endpoint measurement? So with respect to this diffusion, a zone diameter of plus or minus 2 mm difference is acceptable. With respect to MIC, plus or minus 1 twofold dilution is acceptable. So that was regarding the primary factors affecting the conventional antimicrobial susceptibility. So now let's discuss what is the internal quality control which is to be followed for the AST. So this IQC mainly deals with the routine testing, antimicrobial susceptibility testing using ATCC strains. So let's discuss how do we select, maintain, and test these strains. So to begin with, we always have to refer the CLSI guidelines and use the recommended ATCC strains and perform the AST and compare the results with the expected values. So we should remember that the strain selected should match the organism group that is tested. If the organism is a gram-positive coccus, check the IQC for Staphylococcus aureus ATCC 25923. If it is a gram-negative bacil, it's just an example which is quoted. Check the IQC results for Escherichia coli ATCC 25922 and Pseudomonas aeruginosa. So how are these strains maintained in the laboratory? So for long-term storage, store at minus 60 or below in 10 to 15% glycerol. So if available, two stocks may be stored, one at minus 20 and the other at minus 80. One precaution is there. Plasmid-bearing strains should be stored at minus 60 or below so as to prevent the loss of a resistant plasmid. Working cultures are to be subcultured monthly. Store the slants at 2 to 8 degrees centigrade. And prior to testing, prepare fresh plate cultures at least 2 days prior. So the list of QC strains and the purpose of use is mentioned in the CLSI. We can always refer to the CLSI for the same. So we should remember that some strains are used only for disc diffusion. Some strains have can be used only for MIC test, and some may be used for both. And some of them can be used to test specific resistant phenotypes like MRSA or aminoglycan. So mainly we can refer to the CLSI for the so based on our purpose and the test organism of interest, we need to choose from the CLSI recommended ATCC strains. There is the acceptable range which is defined in the CLSI. So always refer to the guidelines mentioned in the M100. We should remember that these tables are updated annually. The QC ranges may be added or modified as per with each update. And any new data which is reflected is always in boldface in M100. So this is just a sample log sheet of the IQC record in which we can these are the different antimicrobial discs. The disk content and the lot number is to be documented. So remember that we have to compare the results of these with the standard ATCC recommended strains as per CLSI and compare it with the recommended range as per the CLSI. So to begin with, what is the frequency of testing of IQC? So always there are two plans which is available and recommended by the CLSI. A laboratory can choose one of them. One is the 30-day plan in which we perform daily IQC for up to 30 days. The other one is the 15 replicate plan for which you can I'll just discuss in detail about the 30-day plan. 15 replicate plan you can refer to the CLSI. So to begin with, perform testing for 30 consecutive days. So check if more than 3 results are out of the total 30 are out of range or not. So suppose there are no 3 results out of range, then we can reduce the testing to once per week. Suppose more than 3 results are out of range, then we need to continue with daily testing until this criterion is satisfied. Once we have shifted to the weekly testing, continue with the weekly testing and monitor for the acceptable range. So supposedly any if there is any out of range result with the weekly controls, then we resume daily testing for 5 consecutive days and check whether it is satisfactory or not. If the satisfactory results are achieved, then we can resume weekly testing. Alternatively, we have to continue with the 30 consecutive days. So as long as the weekly controls are within the acceptable range, we can continue with the weekly testing. Apart from the weekly IQC, there is a CLSI guide which indicates that any modification in the test process, be it change in the disk, for example, a new shipment or a new lot of disk, or a new lot of media which is procured, or supposedly there is a change in the method of inoculum preparation, where we are converting from visual to a photometric based device, or alternatively there may be a change in the method of measuring a zone. So any such test modification, the CLSI recommends to perform a IQC check. So the 1 day, 5 day or daily IQC plan is given in the CLSI. So you can refer to the document for further details on the same. Similarly, for MIC also there is a guide. So you can refer the CLSI guide. So that was regarding the methods or IQC of conventional methods. So now let's discuss the automated methods. There are these are the common compact system, BD Finite system, microscan walkaway, and Trek sensitizer. Am I audible?
Yes,
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 ma'am.
Dr. Archana.
I just got an indication for my internet. Sorry.
Yes, we can hear you.
Yeah. So a laboratory can choose one of the automated methods. So as per the workload and the resources available. So the principle of most of these commercial automated methods are almost similar, except for a slight modification with each other. So the principle is same. It mainly relies on the turbidimetric detection of bacterial growth in the broth medium by use of a photometer, which periodically examines the test wells. So each device has its own quality control procedure. The commercial susceptibility testing devices are not addressed in the CLSI standards. Hence, we are bound to follow the manufacturer's instructions and the package insert. So for further procedure on the QC as well as the limitations involved. So we have to rely on the manufacturer instruction. As a part of the quality control, the manufacturer has has 3 responsibilities. So there are 3 activities that must be performed on any new equipment as a part of the validation of the manufacturing processes. That is the IQ, OQ, and PQ. That is installation qualification, operational qualification, and performance qualification. So these 3 activities are to be provided by the manufacturer. Then what is the role of the user? User must ensure that the products are stored as per the manufacturer's specification. The user is responsible to train the personnel involved in the performance of the automated AST, and also perform IQC at regular interval as per the manufacturer's instructions. So IQC involves, the IQC is similar to the one which we discussed for the conventional method. That is, to begin with, we always perform and monitor QC daily as per the manufacturer's instructions. Use the control strains or recommended by the ATCC and follow manufacturer's instructions and compare the results to the expected values as per the CLSI guidelines. So examine the results for 30 consecutive runs. So I repeat, examine the results for 30 consecutive runs. So once the results are satisfactory, we can shift from shift to the weekly QC. So I'm just taking this Vitek 2 compact system as an example, just because. We need to understand that we have to choose the appropriate card based on the test isolate. So these are the different cards available. So based on whether it's a gram positive or a gram negative organism, based on whether it is oxidase positive or oxidase negative, or check whether it is a yeast isolate, check whether it is an isolate of Streptococcus pneumoniae, or if it is a urine isolate, we have a different card. So the choosing an appropriate card is crucial in the AST of automated system. So each new lot of or any new shipment of these AST cards have to undergo a lot verification. So lot verification is done using the standard QC stains so as to ensure appropriate performance of these cards. What is the frequency of testing? So the frequency of testing should be once every week using all the cards in use. So it is mandatory to test all the cards in use. So the frequency of testing may be once every month or along with each test run in case of a yeast card. This is because of the low frequency of isolation of yeast. So otherwise, it is recommended that all the cards have to be tested at least every week. So these QC results have to be reviewed and documented. And apart from the weekly IQC, any software update in the automated system or any repair of the instrument, CLSA recommends either a 1 day or a 5-day plan. So for IQC. Then what are the other factors which can affect the quality control of automated systems? So it is similar to the one which we discussed in the conventional system. So selecting the colony is a very crucial. Select a individual pure and fresh isolate, and remember that we have to use the manufacturer supplied or validated inoculum medium. Say, for example, in case of Vitek 2 compact system, the saline is usually provided by the manufacturer. We have to use that. In contrast, Phoenix system provides a AST indicator with the Phoenix AST broth. So remember to use the manufacturer supplied or validated inoculum medium. And apart from that, regular maintenance and calibration, operator technique and software update has a crucial role in the quality control. Just in detail about the maintenance and calibration, the instrument has to be serviced annually under the preventive maintenance agreement, and monthly maintenance is recommended to ensure that there is a proper functioning of the optics, movements, and temperature control. With respect to the inoculum standardization, with respect to Vitek 2, we use the Density Check Plus. So we have to calibrate this Density Check every day. So this instrument is standardized daily by using the 0.5, 2, and 3 McFarland, and it should be within the acceptable range. If IQC check fails, testing by Vitek 2 compact will be suspended. Apart from that, there are certain precautions while using the Density Check Plus. So in case of gram positive and gram negative, this McFarland should match 0.5 to 0.63. In case of a yeast, the turbidity is higher, 1.8 to 2.2. Also, prior to use, select the correct mode. Choose whether it's a glass or a plastic based on the tube type, and it is ideal to turn the tube one full rotation while reading to avoid errors, and also periodically recheck a blank tube to verify that zero is set correctly. So the Ma'am, I'm trying to rejoin. So sorry. So sorry, ma'am. Hear me?
Yes, yes, Archana. Yes, we can.
Yeah.
But
Ma'am, where did we stop? I'm so sorry for this.
yes, we were talking about. Yes, exactly. Yeah.
Okay.
Glass
So
and plastic tubes.
These are the certain precautions which are to be taken while handling the or standardizing the inoculum. So select the correct mode, whether we are using glass or plastic. So turn the tube one full rotation while reading to avoid errors, and periodically recheck a blank tube to verify zero is set correctly. So apart from that, operated technique is also equally important. So appropriate pipetting, correct card holding and labeling, and handling of automated alerts or errors are uh, are crucial. So any improper subculturing or filling of the card can result in an inconsistent biopattern. In case the AST is inconsistent, we have to repeat the AST. Also, we have to ensure that the system's interpretive breakpoints match with the correct CLSI guidelines and are updated as per the latest guidelines. So this ensures accurate data interpretation. So it is important that yearly the CLSI updates the breakpoints, and we have to make sure that the software is also updated to the latest CLSI updates. So this was we just discussed the IQC for both conventional and automated methods. So apart from the regular IQC, the laboratory is expected to involve in the EQA programs, that is external quality control at quarterly. So the sites are expected to maintain at least a score of 80% in all the 3 cycles of the EQA. So let's discuss what are the different QC errors. So QC errors can be random, identifiable, or systemic. So the random error can be easily explained. It can be a result of chance and not a system failure. And random error is very unlikely to affect the patient result. And if the problem is truly random, then retesting will resolve the problem. So some examples of random errors, possible reasons for random error could be probably due to contamination of the quality control strains. This is the most common reason. Or alternatively, selecting the incorrect quality control strain for testing. System errors could be due to a malfunction of instrument or due to defective media and or reagents. So system errors do not resolve with repeat testing. This is how we differentiate a random error from a system error. So random error resolves with repeat testing, whereas a system error usually does not resolve. And a system error always affects patient's result. So these are the possible reasons for QC failure. So reason could be either attributed to the QC strain, equipment, or testing supply or a testing process. So use of a wrong QC strain, improper storage, inadequate maintenance, or repeated subculture, contamination, or change in the organism due to mutation could contribute to QC failure. Alternatively, instrument malfunction or use of out of calibration instruments. Then improper storage or contamination of the antimicrobial disc, or use of a defective agar which is too thick or too thin, use of damaged plates or panels or cards or tubes which are cracked or leaking, or alternatively use of expired materials can contribute to QC failure. And what are the other attributes of a testing technique or the testing process? Use of wrong incubation temperature, inadequate or improper inoculum suspension, inoculum which is prepared from a plate which is either too young or too old, or use of wrong disc or improper disc placement, or in fact, sometimes even transcription errors can be a possible reason for QC failure. So there is always a troubleshooting guide. You can refer to CLSI tables for further corrective action. So they just give a list of observation and the probable cause for QC failure and the suggested corrective action also. So ideally, to begin with, we should first identify whether it's a random or a QC error. So by repeating the QC test. So there is a troubleshooting guide for MIC as well. So please refer to CLSI. So just to summarize the corrective action in case of QC failure. So supposedly a QC failure is detected, withhold the patient result and identify the error, whether it is random or systemic. So repeat the QC. So repeat the QC with a pure and freshly subcultured QC strain. This is what CLSI says. Repeat with the pure and freshly subcultured QC strain. Then investigate the cause. So if required, repeat with a new lot of disc or an alternative QC strain, and review the historical trend and troubleshoot. For troubleshooting, you can refer to the CLSI guidelines and document the findings and the action. So if QC passes, then we can resume the testing. So thus, to conclude, all laboratories should prioritize quality control to combat antimicrobial resistance. So the main outcome or the purpose of quality control is improved accuracy in AST results and enhanced confidence in antibiotic prescribing. So these are my references. Mainly refer to CLSI, NCDC, ICMR manual, Eisenberg, Barbara, and manual of the ASM manual. I thank you, and I'm sorry for the technical drawback in between the presentation.
Yeah. Thank you so much, Dr. Archana. And it was a very nice and well-delivered presentation. You made it sound so simple, but we all know as microbiologists in the laboratory, things sometimes can get very difficult when a QC for AST fails. And then we are at crossroads many a times, but that was a very lucid presentation covering, I think, all the aspects, right from media used to the media QC, QC strains to be used, and QC for antibiotic discs, automated as well as conventional. I think you have touched upon it all. So there are a few questions, Dr. Archana, in the chat box. So shall we take them now?
Yes, ma'am.
Yes. So I will read that question out for you. There is one of them who has asked, what are the major differences between CLSI and UCAST when it comes to AST testing? So
see, one is with respect to the QC ranges, ma'am. So the QC and the media of choice. So I mean, frankly speaking, even I need to look into the. I did not tabulate it, ma'am. So I have to re-look into this.
Can I get to this?
yes.
Yeah.
Yes, ma'am. Yes, ma'am.
Yes. See, the major difference is UCAST is easily available. I think that should be the first point I should be telling.
Okay.
The media used is slightly different. Okay, isosensi test, and here we are using Muller-Hinton agar. And the cutoff are actually much different in case of UCAST. Okay, so it's much easily achievable. And intermediate or I which is present is generally not there in case of UCAST. So, and most importantly, CLSI is something which American countries and most of the part of the world use. But we need to buy these guidelines very frequently or every year. Whereas in case of UCAST, it's easily available. So now I think country, like Australia, etc., are also trying to move towards. It's only used in European countries other than France and Germany. but now they've started using, even Australia's moving towards UCAST. When you're talking about the White Phoenix, etc., the breakpoints which they're giving you in these automated systems, some of them are of CLSI, some of them are of UCAST. But please remember, utilize only one kind of, whether it is UCAST or CLSI. These are the only, you should follow one of them for one particular antibiotic. Please do not change it because the zone size may be slightly different. That's why you need to follow one of them, whichever is convenient to your center.
Yes. Thank you, Dr. Suchitra, for that. I think somebody needs to mute their mic. Sajin? Dr. Sajin? Yes. So also, I think Dr. Suchitra well summarized that. What is the basic difference between UCAST and CLSI when it comes to, performance of AST? And also a couple of points. Ma'am already said that CLSI puts forward an I there. That means to say intermediate or equivocal. It more says equivocal, which says that the antibiotic may work if you increase the dose or at a site where the antibiotic concentrates. Can I ask the person? I'm not too sure whose mic is that. Yeah. Whereas CLSI also gives another terminology. We have seen that SDD, that is susceptible dose dependent. But this usage is not seen in UCAST. So in UCAST, you will not see this terminology SDD. Whereas in UCAST, I stands for that if you increase the dose, if you increase a prolonged infusion and better penetration is there of the drug, yes, it may be considered for clinical use. The second aspect between UCAST and CLSI is that breakpoints are different. I can give you one example, like Pseudomonas aeruginosa for piperacillin tazobactam. Under CLSI, we consider a breakpoint which is slightly higher. That means less than 16/4 micrograms per ml is considered to be sensitive. Whereas in UCAST, it is less than 8/4. So like this, there are small differences, and there are small differences even in the disc concentrations that are used. So basically, as ma'am said, UCAST is simpler and they are more rigorous in their MIC revisions, which happen yearly. So whereas CLSI is little more, more conservative in revising its breakpoints. So I think this and a few more will be there if anybody wants to add on.
Rachel, madam, this is Dr. Rudresh here.
Yes, Dr. Rudresh.
Yeah.
Good evening, and please, your domain of expertise.
Yeah, actually, Suchitra madam and you already have concised most of the differences between UCAST and CLSI. I feel if you see the simplicity aspect, CLSI is more simple to use and easy to adopt in any lab settings. Whereas we have tried UCAST actually. UCAST is little cumbersome procedures, whatever he gives. And also the easy availability of the reagents for UCAST is little difficult. But still, whenever the 1 minute, madam. But whenever, madam, wherever the interpretation guidelines are not available for CLSI, in CLSI, then we can go for the UCAST guidelines for some of the interpretation. Especially, we did this for the susceptibility testing for diphtheroids, where the CLSI guidelines was not available, and we went into UCAST. And another difference is any fastidious organism, UCAST recommends to use horse blood, whereas CLSI recommends to use sheep blood.
Absolutely, yes. Dr. Rudresh, are you there?
Yes, ma'am. Yes.
So that was, that was a very nice summary that you gave of the differences between UCAST and CLSI. And I think you just correct me on this. CLSI gives more leverage to the clinical microbiologist when reporting, right? We
Yes,
say that selective
true.
reporting, cascade reporting, and all such things are within our control.
Yes.
going by our local antibiogram patterns and all that. Whereas UCAS is a little more strict, and they give that expert clinical advice, and the microbiologist has to follow that in the reporting.
Correct. Yes.
Yeah, I think
Yes.
so. Thank you, Suchitra ma'am, and thank you, Dr. Rudresh sir, for summarizing these differences very beautifully. And then we have another question, Dr. Archana.
Yes,
Would you
ma'am.
like to take that? There is one person who has asked, what is epidemiological cutoff or ECOFs?
ECOFs, we particularly we use it in with respect. I mean, I don't know with respect to bacteria, but commonly used in fungal antifungal susceptibility, where we do the MIC is not defined by the standard guidelines, and we always look into the regional MIC range. So we look into the regional MIC range, and we say that, say for example, it is from 0.5 to 1 or whatever. So that range is defined as per the regional study, and we compare this as an epidemiological cut. We document it as an epidemiological cutoff, and then we compare our result and check with whether there is any regional difference with respect to the
Yes,
other.
correct. Absolutely. I
So
think
anybody
that's what
else
you said. Would anybody else want, Dr. Suchitra ma'am, would you like to comment on this, the ECOFs and wild strains, wild types?
To put it very simple, wild strain is something which is known to be sensitive to the antibiotics which we are using. Okay. And it is going, you have the MIC, which is the highest for this particular sensitive organism, that is known as the wild type. That will be the epidemiological cutoff. With this, we are comparing the mutants. I would just like to put that as the highest MIC for the wild type is considered is the, yes, it will be the MIC value, highest MIC value for the wild type. What do you mean by wild type? These are organisms which are sensitive to that particular, inherently sensitive to that particular antibiotic. They do not have any, primary resistance to this particular antibiotic. It is inherently sensitive to this antibiotic. The highest MIC for this particular organisms is known as the epidemiological cutoff. With this MIC, we are comparing the possible mutants or the acquired mutant strains.
Yes, thank you, ma'am. That's what Dr. Suchitra said. If you see the wild type, you will have much lower MICs because they are antibiotically very naive. So madam said they may not have much of resistance mechanisms that have been, cross-transmitted. Whereas your other resistant types will tail towards a more higher MICs. Would anybody else like to add on this? Dr. Rudresh?
Yes, ma'am. Yeah. Generally, the epidemiological cutoff values will be given for those antibiotics for which still the we can say not yet established breakpoints are available, and still it is under investigation, or still the data is that much data is not available for CLSI to accumulate and give the breakpoints. And as Madam told, it is applicable for wild types, and it also helps us to note down when the mutants are arising. Okay, if there is any deviation from epidemiological cutoffs, then we should suspect that it is a mutant which is having some mechanisms of resistance to that antibiotic. So it does not define whether sensitive, resistant kind of things. It does not define, and we cannot because we don't have any breakpoints at all in that. In a nutshell, I can say it does not have any pharmacological or clinical significance, epidemiological cutoff values, and we should not use it for interpretation of results. Rather, it should be used for the noting down the newer mutants or occurrence of a drug resistance to that particular organism. As Archana told, most of the time we see epidemiological cutoff values for the fungal isolates, especially for few drugs, we have only epidemiological cutoff values in CLSI for Candida and other organisms.
Yes, absolutely. Yeah. Thank you, Dr. Rudresh, for that. And now we have another question which says, what is a measure to check accuracy of diagnostic MIC testing? So what is a measure to check the accuracy of these diagnostic antimicrobial sensitivity testing? So Dr. Archana, I think you have already spoken about those measures, right?
Yes.
So I think you can just summarize important ones. I think some of them joined a little later and
Yeah. So before releasing a patient report, first we have to check if the quality control is satisfactory or not. So there is a if the QC has passed, then that means we can rely on our patient report. So apart from IQC check, we can just verify if the antibiogram of that particular report is consistent with the organism ID. Say, for example, we all know that Klebsiella is resistant to ampicillin. So supposedly it is sensitive to ampicillin. So very unlikely antibiogram. So in such cases, what we assume or what we can do is we have to relook whether it is actually Klebsiella or not, whether the organism isolate is pure or not. So ideally, we have to repeat the AST. And also the hierarchy of activity of the drug. Say, for example, we should understand or we should know that the third generation cephalosporins are work better than the first and the second generation cephalosporins. So with respect to enterobacterils, until and unless they are ESBL, of course. So in such cases, so where cefazolin is sensitive and ceftriaxone may be, cefazolin is sensitive and ceftriaxone is resistant, very unlikely. So there is a checklist. So it is this checklist is given in detail in the NCDC manual. So you can refer to that. So there is an accuracy checklist for the patient report. So for the patient AST research, so we can always refer to that and then release the particular AST. Anything more to add?
yes, I think you have summarized everything, even in what you said. So thank you for that. And there is another question, Dr. Archana, which asks, what is the basic difference between QC in bacteriology, mycology, virology, and parasitology? I think this is a little, drawn across all boards.
Yes, QC. Today's topic was mainly on QC in, I just mentioned about bacteriology.
Yeah.
So we need to, so that is a different and in-depth topic again when it comes to antifungal susceptibility testing and when it comes to virology, of course, in detail about many. So
correct. Probably, I think to do justice to this, we will take it up as separate topics for postgraduates.
Yes,
QC in antifungal susceptibility, QC in viral diagnostics, etc.
Yes.
Yes. Thank you, Dr. Archana. And then again, a participant has asked, can you please summarize why MHA is better for AST testing and is widely used? Suchitra ma'am? Suchitra ma'am?
Yes.
Ma'am, you had taken up this last time. So can we just hear it from you once again?
Why Muller-Internegar, is it?
Yes, ma'am. Why MHA is preferred for AST testing?
One thing, it is a standardized media which is used by CLSI. Second, the starch etc. which is present in that will absorb the toxins etc. and will not inhibit the antibiotics. Second, the contents of this particular media is well controlled, especially when we are talking about the calcium, magnesium ions or the thymidine content, etc. Because these are the ones which will give a variability in case of certain antibiotics which we are going to test, like cotrimoxazole, tetracycline, etc. That's the reason why when you're doing the QC for the MHA plate, you're testing for the Pseudomonas and also for the Enterococcus, so that there will be no variability. If they do not pass the QC, that means possibility that the calcium, magnesium ions, or the thymidine content, etc., is not right. Because especially when we are buying the Muller-Inter-Agar dehydrated media from different sources, we should be very careful when we are preparing the different, every batch. One. Second, if you are actually buying ready-made media also, like in our lab, we buy because the numbers are very more in number, the preparation may be difficult. Even in those cases, every batch is checked with these organisms to see whether the contents are okay. That's why we make use of MHA plate. And when we are talking about the others, there is not going to be this regularity, or the contents may be slightly different. This is being actually standardized by CLSI. Whereas in case of UCAST, it is isosensitized media which has to be used, which has been actually standardized by UCAST.
Yes. So thanks, ma'am. I think that was very detailed summary of why and Burkholderia cepacia for reporting the sensitivity. Does UCAST have a cutoff? Dr. Archana, would you like to take this?
I have to check, ma'am. I didn't check. I mean, UCAS guidelines. I'm not sure.
Yes.
CLSI doesn't have at this stage.
Yes.
So I didn't check with UCAS, ma'am, for this.
Yes. So one thing I would like to add here is basically from what we understand from, I think people can correct me, even UCAST does not have any cutoffs when it comes to Burkholderia reporting, AST reporting, but it does give ECOFs, that is epidemiological cutoffs are available in the UCAST. And we know the reason in Burkholderia we have some challenges. There is inter-test variability. When you use a different method to test AST, you may get some variability in the results. And one more biggest challenge is these in vitro results many a times do not correlate with the response in vivo in the patient. So this is what we understand. Dr. Rudresh, would you want to comment on this question?
Ma'am, actually, I think I don't remember properly, but I think UCAS does not have any guidelines for the Burkholderia. As you told, it only they define the epidemiological cutoff values only. I don't think they have the guidelines for interpretation of susceptibility.
Correct. Yes, sir.
Yes.
Yes. So thank you, Dr. Rudresh, and also Dr. Kulkarni, sir. Thank you for that. Sir has also given his inputs that MHA has very low inhibitory activity, so allows the growth of organisms very well, whereas a lot of other culture media have some degree of inhibitory activity. So this is what Dr. Kulkarni, sir, has also put in his opinions about why MHA is the most preferred one. Then we have another question, but I think this question, I'm not too sure how to put it. Why double zone of inhibition? But I think that question is actually, why do we use doubling dilutions, right? That I think that is what it was meant to be. Why double zone of inhibition? Okay, sorry. This question reads like this, Dr. Archana.
Yes, double
Double
zone of
inhibition occurs.
That could be due to the resistant subpopulation, ma'am. So it's called as the feathery zone. That's what is mentioned in the books which I went through just prior to this presentation. So in such cases, in case of a double zone of, or else contamination, there could be two strains. So in such cases, ideally repeat the AST and else measure the innermost zone.
That's right. Yes. So thank you for that. Then there's one more question which says that in M100, table 5A gives MIC ranges for QC strains. Can you share some light on why the QC range given for trimethoprim sulfamethoxazole for 80cc E. coli is less than 0.5 bar 9.5, but when Vitek MIC is checked, it comes in the acceptable range, comes as less than 20.
I'm not sure about this, ma'am. Anybody else can take
Yeah.
up this?
Anyone would like to comment on this or give your inputs? Okay, maybe we'll get back with this when we have
Yes,
the
ma'am.
next.
Ma'am, actually, I think we will discuss with Biobureau and give the answer, ma'am, because
Yes,
I
yes,
too
even
have
I
very
thought
less
so.
experience with the
No,
Vitek
Correct,
actually.
no, we have not
Yeah,
observed this. Less than
yeah,
20, I have not observed.
Yes, yes, that's what we have also not observed. So maybe we will
yeah.
take this up and observe it and get back with some more inputs on this. Right. And then there is one last question, but how do we do a quality control for rickettsia and chlamydia? And for mycoplasma also, it's added.
Have to look into this, ma'am.
There is slightly difference in this because these are fastidious organisms. The this one, what is that? Guidelines is also slightly different. It will be slightly more rigid and more stricter because the kind of media used in these organisms are more fastidious, especially mycoplasma, etc. They can get contaminated. So those are slightly different. Quality control, maybe that would be another chapter itself when we are taking the fastidious organisms.
Right. Thank you, ma'am.
Yes.
And I think one last question before we wind up. We have already overshot. How to calculate the MIC for a combination of two antibiotics? I think this is an interesting one. Dr. Archana, I think you will take it, right?
MIC for?
When you want to calculate an MIC for combination of two antibiotics. Like if you want to study antibiotic combinations, aminoglycosides with meropenem or something like that. So how do we go for MIC testing?
Rochelle, I think that
Can
is your subject of interest.
ma'am, ma'am,
You
I'll
worked
answer
on
that
it, so you should
question.
be talking in
Yes.
detail.
No,
No, no,
I
I
thought
have
I'll
that
some
you
answer that
were
shooting
question, ma'am.
also.
No, I'll answer that question.
Yes,
That's
sir.
a
Yes,
nice
sir.
question.
Please. Yes,
Somebody is
it's a nice
trying to
one. Yeah.
look for the synergistic activity. That's why they are asking this question.
Exactly. Yes, sir. Please go
Yes,
ahead.
ma'am. Yeah. Ma'am, actually, this is called synergistic activity or antagonistic activity, or there is an activity between two pathogens or not. We need to see that activity part. For that, there is something called checkerboard MIC. So, checkerboard MIC is the one wherein we are going to do a combination of antibiotics in a range. So let me share one picture just to explain it, ma'am. I'll just share this picture so that I can explain it better. So yeah, yeah. Hope it is visible, ma'am.
Yes, absolutely. We can see it.
So you can see this is one of my ICMR funded study where we looked for the endium inhibitors. So looking for the different inhibitors based on the bioinformatic analysis, we had few molecules like captopril, ciprofloxacin, tetracycline, which has zinc and chelating properties. So we wanted to look for the combination of antibiotics, whether it's synergistically work or not. For example, if you see ceftazidime avibactam, amoxicillin clavulanic acid, piperacillin tazobactam, the combinations, especially the inhibitor combination, has been decided based on this checkerboard. So at what optimum concentration, PKPD, considering PKPD, side effects, combination effects, all those things. So they have decided a particular combination. How they calculate is, say for example, in this particular scenario, you can see the rows are having imipenem in different concentration, ranging from rows is the columns is having EDTA, you can see, This is 8, 16, 32, 64 is the EDTA concentration, varying concentration. And in the rows, we have imipenem concentration ranging from 0.125 to 8. You can see here, so this particular well, for example, assume these L-shaped wells, the first well, I don't know whether I'll just take my pen, just I'll mark it. Yeah. So we can see here, I think, I don't know, and this is not marking them. Yeah, let me see, let me show. Ma'am, is my arrow is seen?
No, sir. No.
No. Okay. So if you see this last but one well, so the second row, last but one, the second column, last but one row. So you can see this is a combination of 8 microgram per ml of EDTA with 1.125 microgram of the imipenem. Okay. So if you this second last but one row, if you go to the right hand side, you can see at 1 milligram per 1 microgram per ml of imipenem concentration with 8 microgram concentration of EDTA, it is getting completely inhibited there. Otherwise, the MIC of this particular strain was 8. It is getting reduced to 1. So this is the synergistic activity. What we calculate is we calculate the fractional MICs. Fractional MIC means MIC of the particular drug with MIC of the the combination, and we look for the fractional MIC values. That means if it is less than 5.5, it is considered as synergistic. Between 1 to 2, it is 0.5 to 1, it is 2, it is considered as no synergy, and beyond 4 is considered as the antagonism. So with the help of checkerboard MIC, we are going to determine this particular the combination effect of the two antibiotics. So even if you can try this trimethoprim and sulfamethoxazole with this method, and you will find wonderful results. Or any two drugs can be interactions can be studied by the particular method of MIC.
Yes. Thank you for that, Dr. Rudresh. And I think Dr. Kulkarni, sir has also put that half checkerboard is also best. Yes, that is less,
Yes.
Ma'am,
Actually,
less
what I showed
tedious
is a half
process.
checkerboard. You can see we are not seeing the entire 96 plate. We are seeing
Correct.
we are using only maybe 6x4 or something.
Correct. Exactly. And also, I think in fixed concentrations also we can test with this, like taking a triangle across the board. No, we can test it like that also.
Yes, of
So I
course.
think
Of course, yes.
we have already crossed closing to 7:30. Let's take one last question. Can automated sensitivity machines, can we switch between CLSI and UCAST cutoffs? So, Dr. Archana? I think we have lost. Yeah.
It all depends on the manufacturer, ma'am. So because it is the manufacturer who updates the software yearly as per the latest CLSI or UCAST guidelines, and also depends upon the laboratory whether to go for CLSI or UCAST cutoffs. So we'll have to ask the manufacturer for further, ma'am. So anybody else?
And
Yeah,
I
what
think
they-
for some of the cutoffs, where there are no cutoffs available with CLSI, they do adopt UCAST cutoffs just for a few of the antibiotics. That's what we understand. But relatively and great. Yes, ma'am?
Yes, that is what they do. If you are going by biomuro, majority of it is CLSI. But
Yes.
what happens is, like in case of cephalosporin sulbactam, this is not a drug which is actually being used widely in America and other countries. So what happens is there are cutoffs which is given in UCAST. So what they do is, when they are doing the software for these drugs which we are exclusively using in the Asian countries, they will give you the UCAST in that particular antibiotic. So it is not a switch. They are actually making the software and giving you the cutoffs. So in between the antibiotics which they have put in their panel, they will try to give you the UCAST guidelines.
Yes. So thank you, ma'am.
Rochelle, you have.
So thank you, everyone. Thank you, ma'am, for that clarification. And I think since we have already crossed 7:30, I think we must close this session. If there are any more questions, please feel free to put it in the chat box, and I will leave this link on for the next 5 minutes so that we can address it. And once again, I thank IIMM-KC for taking this initiative for conducting such master classes for our PGs. I thank the coordinators, Suchitra ma'am and Jayanti ma'am, for your constant support and guidance, to the organizers, and also to Dr. Archana in a very special way, and all of you who contributed to this session by participating and giving your inputs. So thank you. And again, festival wishes to all of you. And let's wind this session here. Thank you, Dr. Archana. So the session will run for some time. If anyone has questions, please do post it.